So today we'll talk about core nutrition essentials for infants and young children. So the outline of my talk will be discussing pathophysiology of poor growth in CKD, the importance of good nutritional management to promote growth and to prevent the complications of CKD, the principles of management, and clinical practice recommendations from our Pediatric Renal Nutrition Task Force. Now, the challenges of managing infant CKD go well beyond dialysis alone. They include nutrition, growth, bone health, physiotherapy, cardiovascular disease, quality of life. And to do this, we need a whole team of people, one of the essential members of the team being our dietitian. In fact, in all our infant CKD clinics, we have a dietitian and a doctor jointly doing the clinic, and this is the level of importance and respect we give for dietetic management. So our little pediatric patients come with their mummies and daddies, but in our Asian society, they come with a whole lot of aunties as well. And the aunties are these well-meaning people, but who have quite a strong opinion and often drag the parents in different directions. Yeah, all the Asian people here are nodding. We know exactly what this is about. But we need to manage this whole unit well, and we need to manage them as one unit to help the child and move them forward. So may I ask, how many of you have a pediatric dietitian in your team? But that's good, okay, but not many, but it's good that some of you do. So I cannot stress the importance of this person enough. And in fact, my predecessor and my mentor, Professor Leslie Rees, had done a calculation which showed that giving growth hormone to 5 children for a year was the equivalent of a dietitian's salary for a whole year. And that would help hundreds of children as opposed to the 5 children on growth hormone. So some simple calculation to keep in mind, and quite a stark statistic when you think of the value of dietitians. So what are the factors that affect growth in children? From the preterm and term babies all the way to adolescence. In the early period, it's the perinatal factors, maternal factors being most important, intrauterine environment, genetic and natural factors. Then in the infants and toddlers, nutrition is the single most important factor that controls growth. In addition, of course, any chronic disease or infections, and the thyroid and growth hormone are important. And then in the adolescent years and in late childhood, it's the sex hormones and growth hormone which become important factors controlling nutrition. So energy requirements for growth are the highest in the first year of life, and you need energy to grow, but grow meaning to grow in height. Yeah? To grow like this is very easy. So to grow in height needs a great deal more energy consumption, and in fact the maximum postnatal growth is in the first 12 weeks of life. By 2 years of age, a child has attained 50% of their final adult height, and a loss of 0.6 standard deviations height can occur within 1 month. So these statistics are important to show the crucial value of following infants very, very carefully, of following their growth, and how quickly you can lose height standard deviation scores if you're not careful in these early years. So looking at nutrition and growth, I think of my whole life now as non-modifiable risk factors and modifiable risk factors. So let's focus on modifiable risk factors, something we can actually do something about. And here nutrition is the single most important factor. Remember, a lot of our infants are salt wasting. The polyuric ones will lose salt in their urine, sodium in their urine. Acidosis, bone disease, anemia, inadequate dialysis, and dysfunction of the growth hormone axis are all important. One of our senior nephrologists in the UK had said, dialysis is easy, it's the feeding that is difficult. And this is really, I think, the more senior you become as a nephrologist, the more you realize the dialysis really is the easier part, and the nutrition is extremely time-consuming and labor-intensive to deliver and to manage consistently. So poor growth is not just simply about growing in height, it is actually about well-being as well. And there are 2 very good studies here that show the importance of this. So for each 1 standard deviation decrease in height, there's a 14% increase in the risk of death. And I think height is an anabolic process. Your body has to be good to grow, healthy to grow, and therefore it's not just statural height in centimeters, it's the well-being of the entire organism that's so important. And a similar study has also shown that for each 1 standard deviation decrease in growth velocity, the risk of death increases by 12%. This chart here is from our European Society registries, which show the height standard deviation in different countries around the world. Now, everybody's squinting to see where their country is. Actually, unfortunately, Sri Lanka is not represented here. But if you look at the closest nearby country, maybe India, India is sort of down here in that pink bar over there. So, but the important thing is that line which says 0 with the dotted line is 0 standard deviations. And you will see that each and every single country is below 0 standard deviations. So height is affected in our children, but it is not something we have to just say, well, can't do anything about it. There's a lot we can do about it. We have a pediatric renal nutrition task force, which represents 8 countries around the world, as you see here, and we have a doctor and a dietitian pair from most countries represented in this. We are endorsed by the IPNA and the European Society for Pediatric Nephrology, and our goal has been, we started in 2018, and our goal has been to develop clinical practice recommendations and to disseminate this information to physicians, to dietitians, to parents and children, to promote good nutritional practice. Now, these are, unfortunately, there is very little high-level evidence in most things in nephrology, but definitely not in nutrition. And so these are not some evidence-based, high-level, grade 1A recommendations, but they are more like an expert opinion. And I'm not trying to sell it to you as a high-level recommendation, but that this is the best we can do as a team from around the world. And these are our recommendations and our suggestions to follow. So we have a number of recommendations here on different aspects of CKD management, nutrition management. I will go through these in detail here. But more important than having a recommendation which is printed in a nice journal and then you put it on your shelf and you dust it down every few months is to actually disseminate the knowledge. And that is really, really important. So all of our documents are available on open access and free of cost at these on the website here, and you can use them and your dietitians can use them as well. So let's look at some of these recommendations, just a few key highlights to go through. So energy and protein requirements for children, let's look at this. This is one of the most fundamental core aspects of nutrition. Now, there are many different recommendations from different parts of the world that give you different RNI, DRI, DRA. There are many different terminologies. We've used this term suggested dietary intake, which is the average of these different published values in a sense. You can see the Gaussian curve over here. And for energy, it's at the top limit. So we define the upper and lower limits where 50% of the requirement of the population is met. For protein, we define plus minus 2 standard deviations like a Gaussian curve and suggest that protein should be maintained within these limits. So for the energy requirements for infants with CKD, we've provided the details over here. Of course, nobody needs to memorize this. It's all available, open access. But remember, to promote optimal growth, we need to adjust the energy intake towards a higher end of the SDI. But there are many studies, mostly observational, which say that a dietary intake around 100% of the estimated requirements for a healthy population is enough for growth in a patient with CKD. So there's a concept, there's this thing that CKD, you've got to overfeed them. You don't need to overfeed anybody, any organism in the world. You need to give them the adequate amount of energy that would be given to any child of the same age, yeah? And all of the recommendations are similar here. If a child has a very stunted height, we use the height age as an approximation. So you don't want to underfeed them. You want to use a height age as an approximation to give them the best nutrition. Now, looking at protein, so again with protein, there have been some misconceptions and some myths that a low protein diet may be better. There was a very good randomized study coming from Germany, from the Wingen group, that said growth was no different in this population of 226 children, where the lowest safe protein intake and versus unrestricted intake had similar results. Again, Cochrane meta-analyses have shown that low protein versus normal protein does not make a difference. So our recommendation is that the protein intake at the lowest end of the range is the minimum safe amount, and we do not reduce below that value. Remember, urea values have to be managed adequately. Urea comes from many different things. So remember, urea could be from a hemorrhage, it could be a breakdown of protein, it could be steroids, it could be a number of different factors. So low urea levels may indicate insufficient dietary protein, and don't ever compromise nutrition in order to manage the urea levels in your dialysis patients. If the urea is high, you need better dialysis, yeah? And if the urea is persistently high, despite adequate dialysis, despite looking at all other aspects of the clearance of urea, remember, it may be that your energy-protein ratio is inadequate, and the child may need more energy rather than less protein. Protein intake, especially in children on PD, may need to be higher because of protein losses. The same patient who will lose protein in their peritoneal dialysate will also lose sodium. So be aware of this and adjust it accordingly. So here is just a graph of protein, a chart of protein intake at different ages, adjusting up for hemodialysis and for PD. Looking at nutrition in terms of whether or not a child might need enteral feeding. So enteral meaning tube feeding, sorry. So here we don't wait for a child to lose standard deviations in height, because once you lost that, it's very difficult to regain it. So having a proactive approach is much better. And the types of gastrostomy devices include a Malico catheter for a temporary device, the PEG or the percutaneous endoscopic gastrostomy as a Freeka tube, or the balloon type of devices as well. And here the device is actually inserted in the patient. Gastrostomy device insertion can be a percutaneous endoscopic gastrostomy, like the picture on top. It could be radiologically inserted, an open procedure, or a laparoscopically assisted procedure. So why am I giving you all this information, and what's the difference? So an open procedure, by definition, will prevent spillage of gastric contents into the peritoneum. Now, in a person who's not on PD, it's no big deal. The macrophages in the peritoneal cavity will quickly engulf any spillage and get rid of it. In a person who has PD fluid in their belly, the PD fluid has sugar and it's a nice warm fluid. This is exactly what your culture medium in the laboratory is. That means if there's one bug that has spilt from the stomach into the peritoneal cavity, it will very quickly multiply and become rip-roaring peritonitis, including even a risk of fungal peritonitis. And therefore, remember that any percutaneous procedure is a blind procedure, and it has a high risk of spillage of gastric contents into the peritoneum. Therefore, you must, in a patient on PD, you must try and, or a child who might need PD, if you have the luxury of time and planning, then first put in a gastrostomy feeding tube and then put in your PD catheter, and prevent leakage of the gastric contents. This study from the US showed very nicely that there is a 3-fold higher risk of peritonitis in a child with a gastrostomy, in an infant with a gastrostomy, compared to an infant without. But this is not, this is something that is preventable. And if you approach it correctly, and you make sure that you use antibiotic and antifungal prophylaxis, then you are safe with having a gastrostomy insertion in a patient on PD. So again, to stress, we try and do a PD catheter, we try and do a gastrostomy insertion before putting in a PD catheter, and we cover for gastric spillage with antibiotic and antifungal prophylaxis. Now, what are the benefits of this? So we did this is a very recent paper we have, looking at gastrostomy feeding and growth, and following these children from under 1 year of age all the way up to 3 years. You see that the weight standard deviation improves in these children with gastrostomy feeding, with the highest improvement in the first year of life, and thereafter it remains steady. And most of these children attain a weight standard deviation score above 2 standard deviations. The height standard deviation is quite challenging. It has not increased, but neither has it decreased. So at least you're maintaining a static height standard deviation in these patients. They're not losing height. And in body mass index is therefore also improving because weight is improving. In the Asian situation, I come from India, and when I teach in India, many people will say to me, "Oh my God, do you, our patients refuse gastrostomies." So I know senior physicians, nephrologists in India who will say, if your child needs PD, especially as an infant or a young child, it comes as a package deal. You have to have a gastrostomy to have a PD catheter. And when you have both, then your improvements in the well-being and the health of your child will be far greater. So not to succumb to the family, I know they will go to a different doctor, but you have to have that confidence in your treatment to say that I will only do this as a package deal. You must have a gastrostomy to get the best outcome from PD. Moving on, looking at the management of calcium and phosphate. So this graph here shows you, this is for children on PD, with over 900 children on PD, and it shows you that 45% of all children are hyperphosphatemic when you look at the whole cohort. But when you look by age, only 6% of infants have hyperphosphatemia compared to 80% of adolescents. Now, it's not a different species. There's nothing going wrong in that. The thing that happens in adolescents is that they're having more processed food. So when we look at phosphate, you can have organic or natural phosphate and inorganic phosphate. Inorganic phosphate is in the form of phosphate additives, which are used as raising agents. They extend the shelf life, they improve the color and flavor of food. But they can increase the phosphate content of food by more than 50%. And the phosphate in inorganic foods is 100% bioavailable. All of it is absorbed. From natural sources, only 30-40% is absorbed. So this is an important factor to keep in mind. One Coca-Cola will give you the equivalent phosphate for a whole week in all of us. Now, you and I can pee it out. Our PD patients, our dialysis patients can't. So one Coca-Cola and you're finished for a week, yeah? Nothing else matters. So we look at the phosphate content in the foods, and these E numbers, in terms of the preservatives in Europe at least, E numbers indicate the different types of phosphate in the food, and we need to be sure we avoid it. Now, foods that contribute to calcium also contribute to phosphate. So you see here that the main sources of calcium for children are dairy products. They also include meat, fish, and eggs as well. And you see that foods rich in calcium are also rich in phosphate. So be very, very careful. What does it mean? It means that if you have a patient who's strictly adhering to a phosphate-restricted diet, they will become calcium deficient. And this is an important concept. So this graph here shows a very nice linear correlation between dietary calcium and dietary phosphate. And when we looked at this compared to green bars, which show the calcium intake in healthy children, in the red or pink bars, you see that the calcium from diet alone is much reduced in children with CKD and on dialysis. And only when you use calcium-containing medications does the calcium requirement increase. So these children are becoming calcium deficient when you try and restrict their phosphate. However, phosphate adherence is also a very, very difficult thing. And we did a study, a dietitian did a study, looking at whether the knowledge of phosphate deficit in children and young people will actually translate to a better habit of restricting phosphate. And this is really interesting. Everyone knows smoking is bad, yet people smoke, yeah? So knowledge does not necessarily translate to habit. And that is what we saw as well. We saw that there was a big discordance between the knowledge in patients and in parents and caregivers versus actually implementing this. And looking at phosphate management, we first start with limiting processed and ultra-processed foods. And if there's one thing you can do, especially in children on a Western diet, is to limit this. And Western diet has crept into every corner of the East as well now, right, from the smallest village. So the minute you land in Sri Lanka, there are big advertisements about pizza and Coca-Cola. That's the first thing I saw as I came to Sri Lanka. So you can imagine my blood pressure. But this is where ultra-processed foods is now everywhere. And this is where all of these high phosphate the high phosphate comes from. And again, remember, bioavailability is almost 100%. We also have animal-based protein, especially red meat, which has high phosphate. We need to encourage more fruits and vegetables, need to look into home-cooked real foods, increasing a plant-based diet, and limiting red meat as best as possible. My next talk this morning is on CKD-MBD management, and we'll talk about this in detail, controlling hyperphosphatemia. So looking at potassium very briefly, again following a similar pattern. So the first thing for potassium management is to remember that potassium can come from medications, and medications are perhaps the highest source of potassium in our diet. So we need to look at that and manage the high potassium containing medicines if possible. We then look at the, again, processed foods that contain potassium. Remember, low salt is actually potassium chloride. So be careful that your patients are not caught in that trap of trying low salt sodium. Yeah? Again, low nutrition quality foods such as beverages should be avoided because of high potassium. Plant-based foods, animal-based foods are higher in this. Cooking processes can remove and leach out the potassium from the food. In addition, plant-based sources always limit the amount of potassium absorption. And in CKD, the renal excretion is affected, and manage the potassium-rich high potassium foods carefully. Dietary fiber is similarly extremely important and gaining more and more importance in healthy people as well as CKD, and knowing that high fiber foods will reduce cardiovascular mortality and actually improve number of different outcomes from cardiovascular to survival to even cognitive function in many, many different ways. So a plant slant diet is perhaps very good. Nobody is saying stop all your meat. That's impossible for the non-vegetarians. But a plant slant, encouraging more plant-based foods, is really important. The microbiome we can talk about a lot, but I want to quickly show you also that we have all these different practical guides that you can download from this website free of charge for your dietitians, for yourselves, for your patients and parents. We have dietary booklets for the families. We have these food conversion charts and simple charts they can use even for when they go shopping. We have cooking methods, and importantly, we've taken our nutrition task force work to many different parts of the world, from the Middle East with translations to translations within India as well, and the South Indian diet would be close to applying to what you have in Sri Lanka. Now, translation doesn't simply mean a language translation. That's easy to do, and that's quite, that's not a big deal. The translation actually means translation to the dietary habits of a particular region, and that is really important because different foods are eaten in different parts of the world, and you need to be familiar with the nutritional composition of foods in every part. So adapting to the Asian diet is something we worked very hard on for Southeast Asia. This also applies to Malaysian and Singaporean diets that we've looked at, and we've spread our nutrition work everywhere now. So good nutritional management can improve growth, reduce the complications of CKD. Early intervention is critical to prevent malnutrition, and prevention is always better and easier than trying to treat something that you've lost control on. And invest in or work closely with your dietitian. Encourage enteral feeding early in the course of CKD, and we have the resources available as you need. So finally, a quick plug for our course, Advances in Pediatric Dialysis. This is an online two-half-day meeting, free to all people from low and middle income countries, so free for all of you if you're interested. And this is our 7th year of running this. If you're interested, please do join. Thank you very much.